Am I audible?
Yes, ma'am. Greetings and a warm welcome to everyone. I'm Srivshi, the assigned moderator from Planet. It is my proud privilege to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate to have the valuable support of esteemed doctors and express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform, Planet. It stands as one of the largest live digital CME platforms in India, providing a space for doctors to create and share medical content. Now, I'd like to extend a special welcome to today's distinguished speaker, Dr. Shilika Lalwani ma'am. Ma'am holds degrees in MBBS, MD, DLB, DRNB in endocrinology, PGDGM. Ma'am is consultant endocrinologist at Oriya Clinics. And today, ma'am will be talking on the topic continuous glucose monitoring, transforming diabetes care. So, without any much further delay, ma'am, now I would like to hand over the session to you. Kindly proceed with the talk, ma'am.
Thank you for the kind introduction, Shreyasi. It is my pleasure to be on this platform, and I'm here to simplify something that might be considered as a very complex topic to all of you. However, this is the need of the hour, and this is one of the latest innovations in diabetes that we all are going to deal with sooner or later. And the India has already been declared as the World Diabetes Capital, CGMS is something that we should all be aware about. With more and more people coming in and asking us, more patients asking us for CGMS as their routine standard of care, it is as a job of clinician to interpret these reports and decipher it to the patients. So why do we need ambulatory glucose profiling? Like we all must have seen something called as ambulatory BP monitoring, and this kind of BP monitoring is much better than the routine clinic monitoring of the blood pressure. Similarly, why ambulatory glucose profiling, and why do we need to even demystify these reports? So we know that the triangle of diabetes care. So we do have routine tests like HbA1c or self-monitoring of blood glucose. And while these things are they have been in place for many years, it is time to upgrade because these tests might fail to uncover certain gray zones in our diabetes monitoring. So HbA1c is good for a reasonable overall data, while there are few areas or lacunae where the self-monitoring of blood glucose and HbA1c fails to correct. We cannot assess glycemic variability or the glucose variability. That is, in simple words, the blood glucose fluctuation that happens throughout the day that we are not able to assess with the HbA1c. While your overall HbA1c might seem to be normal, the patient might be experiencing frequent hypoglycemic episodes followed by frequent hyperglycemias. And these cumulatively will give an average of a normal HbA1c, which in sense is a false image of the blood sugars being controlled throughout the day. While the recent studies have also proven that more the glycemic variability, higher are the chances of complications associated with diabetes, both the microvascular as well as the microvascular. While HbA1c fails to detect certain areas, it does not detect hypoglycemias, and SMBG might not be feasible in each and every setup. So what is basically a CGM? So CGM is a wearable device that measures glucose in the interstitial fluid. While self-monitoring of blood glucose primarily looks for the capillary blood glucose, SMBG profile that we do is usually a finger prick test. So a wearable device is usually something that measures the blood glucose levels in the interstitial fluid. So it gives us a very real-time data with RT-CGMS, or there could be intermittently scanned variety of CGMS. The commonly available CGMs worldwide are Dexcom, G6, Freestyle, Libre, Sensonics, Eversense are approved. These are approved for blood glucose monitoring. In India, we commonly use the Medtronic Guardian 4 and the Freestyle Libre 2. So Freestyle Libre 2 has recently been launched. Before that, Freestyle Libre and Libre Pro were available. So these are commonly available CGMs in India. So what does a CGM measure, and how does the data actually reach to us? So we have to understand the basic parts of CGM, that are the CGM sensor, the receiver, and there is something between the sensor and the receiver, that is a transmitter. So a receiver could be a device that comes in with CGMs, or it could be even a mobile phone. So with the recent CGMs, the NFC-enabled mobile phones are become receivers, and there are transmitters that transmits the data from the sensor to the receiver. So so once we apply a CGM, we need all these things in place, and the wearable device can be in place for a week or even 15 days depending on the type of the CGM that we are using. So there could be a physiological lag between the CGM reading versus what we see in the reader versus what actually is in their blood. So when blood glucose levels are stable or they're changing very slowly, the readings can be very similar as compared to what is actual reading versus what is seen in the reader. However, if the blood glucose levels are very rapidly changing, the numbers can be quite different and the lag times can be longer. So we need to be aware of the arrows that are available while we are looking at the reading. So we don't have to just look at the reading, but also look at the arrow that comes next to it, and it will show the direction of where the blood glucose is heading. So there are few standardized metrics, the matrices that we should be aware about. The number of days that the CGM can be worn is limited. Like we discussed with the Medtronic one, it is for 7 days. With Freestyle Libre, recently it has been upgraded to 15 days from 14 days, which gives one extra day to the patient, and percentage of time that the CGM is active. So even after you're wearing the CGM for 14 days or 15 days, at least 70% of the times the CGM should be active. So this is actually the first thing that you should look into the report, that how much percentage of time the CGM was active, and the ideal number is more than 70% of the time that CGM should have been active in this period of 14 days or 15 days, whatever the CGM has been worn. There is a reading called mean glucose, and basically another reading that we get is glucose management indicator. So GMI in CGM matrices is nothing but HbA1c translated into the 14 days of CGM. With CGM, one additional measurement that we can get is glycemic variability. So this glycemic variability is the measure of glucose fluctuation from hypos to hypers. So we have to ideally have this glycemic variability under 36%. So this is nothing but statistically derived coefficient of variation. So ideally, when the coefficient of variation is less than 36%, the variability is less, so complications are lesser. This kind of variability was previously not available in any of the blood sugar testings that we used to do, like HbA1c or self-monitoring of blood glucose. So patients might come and tell us कि blood sugar fluctuation is too much, that the morning blood sugars are very high, and then evening hours, every after lunch, I get a hypoglycemic episode. And then the doctors are confused whether he or she needs an incremental dose or a decreased dose or some change in the regime. So glycemic variability helps to target that part. One important variable that we look into the CGM metrics, and we will look when we are looking at the AGP reports, is time and range, and the time above range and the time below range. So once we see the time and range, which is ideally TIR, so the ideal readings of time and range should be at least 70%. These cutoffs, 70 to 180, are for non-pregnant adults, while it could be different for a younger patient, or in cases of type 1 diabetes, or even in cases of pregnancy, where the upper limit of time and range is not 180 but 140. So we can actually set our range and then decide what is the time and range. For example, in an elderly patient where we don't want the blood sugars to be very low at any point of time, the lower limit can be switched from 70 to let's say 100, and the upper limit can be set at 180. So the time and range, which comes in the number of percentage, tells us that how many readings over the period of 14 days were in this range that we have pre-decided. Then there comes the concept of the time above range. So time above range is also divided in level 1 and level 2. So level 1 hyperglycemia versus level 2 hyperglycemia. So higher the level of hyperglycemia, lower is the expected value for that during a period of 14 days. When we discuss time above range, it tells about hyperglycemias, but we are more worried of hypoglycemias. So we also need to look at the time below the range. So these indices would be very clear once we look at the AGP report. And similarly, the time below range is also divided into level 1 and level 2 of TBRs. So level 1 of hypoglycemia is 54 to 69 milligrams per deciliter of blood glucose, while level 2 is less than 54. So these are the basic matrices that we need to look in a standardized AGP report. So this is what we were talking about. A graphical representation makes everything much colorful for the patient to understand, and for the doctor to explain it to the patient. So while we are looking at time and range, we can see the time and range more than 70%. So this is kind of an ideal time and range for someone who's suffering from type 1 diabetes or a type 2 diabetes. However, the targets could be different for older individuals, and there could be still different range or different cutoffs for a pregnant patient. So depending on the type of the patient that we are dealing with for CGMs, we can discuss what ideal range that the patient should be in and they should lie in, and what are the levels of hypoglycemia that is accepted or hyperglycemia that is accepted. So based on that, we can define targets for each patient individually. So while time and range and HbA1c are two different matrices, they are directly related, and we can actually correlate as we see that increase in time and range will subsequently result in reduced HbA1c. So a patient wearing CGM for the first week, if the time and range is let's say 50%, 10% increase in time and range in the subsequent week will result in overall reduction in HbA1c. While HbA1c is not monitored every 10 days or 15 days, there is a pseudo indicator that is actually a reflection of HbA1c, that is the glycemic GMI indicator that we previously discussed. But more and more usage of CGMs will help patients come back into target ranges more stringently, which overall helps in uh, improvement of the HbA1c. Why and from where the 70% cutoff from for time in range came, it was exactly when the HbA1c was around 6.7%. So this is something what we target for a type 1 or a type 2 diabetic patient who are not of a very high risk category. So the components of this AGP report, basically the map. So what we can see in the green is the time and range, the yellow, light yellow and dark yellow as time above range level 1, level 2, while similarly for the red colors that is low and very low, that is time below range. But more importantly, what we have to see in this is the percentage time that the CGM is active. And that should be more than 70% for this report to be a readable report or to be an adequate report. We also look at the average glucose, the GMI, and the glucose variability. In this case, we can see that even though the time and range was 47%, the glucose variability was very high, which was 49.5%. So and the CGM has been active for 99.9% of the time duration that it was worn, but the glucose variability is very high, and we can see that the time above range was very high as compared to what were our expected targets. So in this case, we have to reassess the entire graph and then rediscuss the management plans with the patient, and we can decide on what insulins to add, where to change, and this is where we do all those things. So this is for our understanding and explaining the patient, and this is for us to help patient monitor the entire duration where the CGM was being worn, and then decide a plan of action accordingly as per the graph. As we can see, the green zone, that is from 70 to 180, was the time in range, and there has been a significant number of hyperglycemic episodes during this time period. So this is basically an average of entire 14-day graph, and wider the graph, wider is this image, more is the glucose variability. The narrow is the image, everything comes between the light blue lines are very closer to the black line, so lesser is the glucose variability. So when we look at this report, it gives us an average of the overall 14 days. While when we look at individual reports, what we can see is how the graphs behaved on each day. So we have to also take into consideration special days like weekends where patients tend to indulge more in like eating outside or eating junk food or something like that, versus on weekdays, which are the regular days. And we also have to note special occasions like somewhere where the patient had a lot of exercise and a lot of walking, which resulted in hypoglycemia. Like we say on 6th, we can see somewhere there has been a hypoglycemic episode in the in the evening hours, while on 7th there was no such event. Again on 8th, we can see a red marked hypoglycemic event. So this could be probably because patient has been taking evening walks but not regularly. So we have to discuss each and every day and each and every graph with the patient and what went wrong. To make this journey very easy, we can ask the patient to maintain a log, a diary, or something that helps us understand what went wrong. So this diary could include diet, exercise, and special situations wherever necessary. And after 7 days of wearing the CGM, we can call the patient back, assess this, and then try to make certain changes, and then reassess again in the next 7 days. So what are the steps in interpreting an AGP report? Basically, we need to identify where which patients require them. We have to start in with a sensor numbers, check the dates, check the adequacy of the data. Once data is adequate, then we can go ahead and start marking where the patient has been taking insulin doses and where the patient has been consuming meals and some other small things that matter in blood glucose control. And once you see certain things that do not match as per the routine, you have to specifically ask the patients and ask why a certain area is looking very hyperglycemic or hypoglycemic, and ask them to specifically recall what they had in that particular duration or what was their exercise or that kind of routine. So once we identify these patterns, we have to look for hypoglycemic areas where the risk is very high. We have to identify the patterns where the blood glucose is spiking very high. And we have to assess the variability and throughout the day and assess the stability of blood glucose. And we can also compare with any previous reports if the patient has been using CGM before, and then decide and discuss on an action plan. So while using CGMs, let us discuss some few practical tips, especially for the patients who are on insulin therapy. CGMs can help us assess a basal dose of insulin. Looking at the graph, we can see that it is very plateau or a very stable graph. So this tells us that overall the blood glucose has been very stable and the basal dose has been adequate. So overnight, especially at the night time, we can look from 0 hours to 800 hours. The blood glucose has been significantly normal. So this gives us the confidence that the basal dose that we have been giving to the patient is correct and the glucose should stay stable overnight. However, if we see a rise during this time period, we can make a decision that the basal dose is lesser than what is required, and this will result in a recurrent rise in blood glucose every morning. When the patient wakes up, he or she will say कि every morning I have, doctor, I have very high blood sugar levels. So this graph can help us identify and differentiate between the dawn phenomena and the Somogi phenomena, and we can discuss the basal doses that the patient requires. And like in this case, we can just increase the basal dose and help the patient to stabilize blood glucose and reduce the morning blood sugar spikes. While there could be a recurrent fall, so this fall can actually result in a morning hypoglycemia or a hypoglycemia midnight followed by a hyperglycemia in the morning. That is the Somogi phenomena. So in such cases, overall the insulin dose, the basal dose needs to be decreased by 10%. We can also calibrate the time when the patient is eating the meals and having their insulin shots. So if the insulin to carb ratio is correct, the glucose level should return to target levels within 4 hours. Like in this patient, we are assuming that the patient is having something around, let's say, around 6 p.m. But by 8 p.m. or by 10 p.m., the blood sugar levels are normal. While the theory looks different, practically the graph will be more or less stable. So if the patient, however, is taking the IC ratio is too low, like the patient is taking more carbs as compared to the insulin, the blood glucose levels won't return back to normal after 4 hours. And what we can see in practice is a spike in the blood glucose levels after 3 to 4, and persistent spike after 3 to 4 hours. And similarly, in the different scenario where the insulin doses is higher than the carbs taken, patients might experience a postprandial hypoglycemia as compared to a normal stable blood glucose. In this case, the insulin dose needs to be reduced. There could be variable postprandial effects if the carb estimation is inaccurate or the calculation of insulin dose is variable. Postprandial glucose levels will be very unpredictable in such patients. So, in this can also help us identify what is the exact time that the patient is taking insulin. Patients on short-acting insulin are usually advised to take insulin 15 minutes prior to that meal. If the patient is delaying the meal or if the patient is delaying the insulin dose, the spikes can be different, and patients can experience hyper or hypoglycemia depending on the time of the insulin, and insulin spikes might not match to the blood glucose spikes. So effect of insulin bolus uh, on the AGP chart is also seen, and sometimes patients happen to do bolus stacking, that is taking a repeated
Hello,
insulin
ma'am.
dose again.
Ma'am, sorry for the interruption. Ma'am, could you please
Yes.
tint your camera just a little bit up because your head is not coming. Yeah, yeah. Okay,
Is
fine.
it okay now?
Yes, yes, yes. Fine.
Okay, thank you so much for that. So, effect of insulin on bolus could be a late bolus or a bolus stacking that could actually give us hypoglycemias, and this can be very easily picked up with a AGP graph. So, patients might not tell us about the late boluses or bolus stacking, but they just tell us, yes, I have taken insulin, but the timing also matters. So, we can actually reinforce the timing of the insulin and the meal times to ensure that the graph is more or less smoother. Snacking can be a very common cause why the blood glucose rise, because sometimes the patients might not even consider that the snacks that they are having is going to result in a high blood glucose level. And sometimes there could be some midnight binges or cravings that you can easily pick up on a AGP chart. The dawn phenomena, like we discussed, the blood glucose increases at 3 a.m. and then eventually leads to early morning hyperglycemia. This can be tackled by increasing the nighttime insulin dose. Coming to some case scenarios that we see in everyday OPD, like a 44-year-old walks into my OPD and she's diabetic for past 6 years. She was on mixed insulin twice a day, and she told me she has a very erratic blood glucose on SMBG. Some values showed levels of as low as 60 to as high as 250. So this was an ideal case scenario where we could think of using CGM because the variability is too high, even though the HbA1c looks very nice. So when we did an AGP chart for her, this is what we found. We can see that there's been early morning hyperglycemia. Again, the hyperglycemia continued, followed by normalization of blood glucose around lunchtime, and again eventual hyperglycemia around dinner, and then eventually hypoglycemia at night time. So we can see that she had low blood glucose in the night while her morning blood sugar was very high. So while assessing uh, this low blood glucose as well as the variability in blood glucose, we can assess for the meal times that the patient has been having her meals, and how exactly she's been taking the insulin. We can see the GMI, the glycemic variability is very high in this patient with hypers and hypos. So basically, what we did was we switched this patient to a basal bolus insulin to provide her a very stable basal level, followed by boluses when she was having her meal times with frequent SMBGs. And we can repeat CGM in 3 months in such patients to assess whether she has achieved a normalization or not. So after 3 months, her blood glucose level and time in range was much better than her previous CGM report. So another case where an 18-year-old type 1 diabetic came with SMBG that looked very much in target range, but his HbA1c was very high, and he was already on a basal bolus insulin regime. In such a case, when SMBG is in target, you are not very sure that which insulin to be increased, whether it is the short acting one or the long acting one, or where is something that is going wrong. So this is how the AGP looked like, and you can see everything is in higher range. So this I call is technically a wastage of CGM. So when everything is in high range, yes, average blood glucose came out to be 252. So the times when he was checking the blood sugar levels were very routine time, like his fasting or post breakfast. But eventually he persistently had hyperglycemia throughout the day, just increasing. This is how his everyday daily reporting looked like, and we can see most of them is in yellow ranges, while there have been a few hypoglycemic episodes as well. So in this case, what we found out the problem was the glucometer. So that is where all the SMBG's readings were coming out to be normal. With a strict lifestyle modification and a very disciplined SMBG with the new blood glucose, new glucometer, and a continuous basal bolus regime, the patient started doing well. And then when we reevaluated him after 3 months, he was much better, and the glucometer really needed to be replaced. Another case of a 65-year-old male who came with type 2 diabetes for past 25 years on mixed insulin with a good HbA1c of 6.5, complained of early morning tiredness, headache every day. So this is what his AGP chart looked like. Even though the estimated HbA1c was normal, average blood glucose looked very normal. But every time we could see there was a nighttime hypoglycemia, which led to early morning hyperglycemia. So we started fixing carbs for each meal with a regular mid-meal snacks. We changed the insulin to mixed insulin 50-50 instead of a 30-70. This gave a better post-meal control to the patient and lesser bolus as lesser basal dose as compared to the previous one. So this helped fix the nighttime hypoglycemias, and after reevaluation after 3 months, the patient was much better, and the morning nighttime hypos had uh, perpetually resolved. So some a few practical tips while we are using CGMs. While accurate CGM insertion, the site preferred is usually arms. It could be done in any subcutaneous tissue, but arms are more preferred as sometimes the CGM requires scanning. So like Freestyle Libre requires every 8 hourly scanning. So arm is a much preferred site because we can just hold our phone like this and scan from the scanner, and this is doable in any clinic clinical setting. We should avoid scanning immediately after meals because there could be artifacts, and our decisions should not be made on that immediate blood glucose level just after the meal. We should wait for some time before we are actually able to decide on the insulin dose. First 24 hours may be unstable. So the first day of the CGM is usually not considered, because once the CGM is installed, sometimes the warm-up time is 2 hours, and first day report might not be very reliable. So don't jump onto conclusions on day one of CGM and suddenly very over enthusiastically change doses on day one. Give it a couple of days. If even after 3 days everything is in the hyperglycemic range, that is the point where we should intervene. But if in a routine clinical setting, we can call the patient back after 7 days. And what I practice is, the day we put on the CGM, we give them some few tips that they can take care of at home. And if they're not able to manage, again we reassess at day 7 of the CGM insertion, and we retitrate the entire dose and then decide what has to be done in the next 7 days, and then again see after 7 days how that has to be dealt with. So there could be compression loss. So compression loss could be sometimes if the patient is sleeping inadvertently or over the CGM for over a long time. The interstitial blood glucose levels might be low due to reduced blood supply in that particular area. So there could be other indices, that is the mean average recording of the blood glucose. So MART could be less than 10%, and this is actually a good accuracy. Common misinterpretations. So while ignoring the coefficient of variation, that is the glycemic variability that we discussed about, overreacting to a single day spike, not giving dietary advice based on AGP. So AGP is not just for the endocrinologists or physicians who are managing the blood glucose. It is also for the dietitians who are managing their meals and the carbs and what goes in. So, treating HbA1c without treating the time below range. So, this is the gray zone where we forget about the hypos and we are just acting upon the HbA1c and increasing the insulin doses just to make the HbA1c normal. So, we also have to take into consideration the hypos that are happening across the time period. So the take-home messages from my end could be, CGM gives us a very valuable information that is much beyond the HbA1c, and AGP report is the most actionable part of the CGM. So not looking at the AGP report is waste of the CGM. And we always have to start reading from time below range, time in range, to coefficient of variation, AGP curve, and the patterns. We have to fix the hypoglycemias before intensification, because the hypoglycemias are more harmful than hyperglycemias per se. And AGP based titration might improve outcomes that are just more than HbA1c based titrations. So even though the HbA1c looked normal, the patient already had a lot of glycemic variability that is fixed with use of a CGM, that cannot be done with HbA1c alone. So it is the patterns that reveal what the average hides. So not just trusting the average, but also looking at the patterns gives us immense information about how the patient has been doing the entire duration, an entire week or entire 15 days of the CGM reports, and it gives us a gateway to patients' overall well-being. So, thank you very much for the patient listening. I am Dr. Shilika Lalwani Budhwani. I am an endocrinologist based at Raipur, Chhattisgarh, and I run my own endocrine center by the names of Uraya Clinics. And I'm also dealing with type 1 diabetes and basically all patients who are frustrated come with madam हमारा sugar control नहीं हो रहा. So this is what I specialize in and help people find correct glycemic patterns and improve the quality of life. Thank you so much.
Thank you, ma'am. Thank you so much for the comprehensive talk. It was really very informative one. So now, ma'am, we have received few questions from our participating doctors. With all your permission, I'm sharing the screen. I hope my screen is visible to you.
Yes, your
Yeah.
screen is
Yes,
visible to
madam.
me. So the first question is, how has CGM impacted long-term outcomes and patient quality of life? I think we discussed about the glycemic variabilities and the patterns that actually affect the long-term outcome, because same thing that we discussed, that hypoglycemias and hyperglycemias coexisting in a patient, leading to the immense glycemic variability and still a normal HbA1c. So in this term, when we look at the patterns, our management is very fine-tuned to the patient's requirements, and this helps us reduce the hypoglycemic events and reduce the hyperglycemic events as well, and in turn give them a more stable blood glucose throughout the day and reduce the fluctuations. Thank you for this question. Very insightful question. Yes, what is the role of CGM in type 1 versus type 2 diabetes management? So, while CGMs is a very good tool for people with type 1 diabetes, even in type 2 diabetes where we are using insulin, because CGMs can help us fine tune the insulin doses, it can be used in patients who are on OADs as well. So, patients with OADs, if they come with, let's say, deranged blood glucose or symptomatic hypoglycemias, it helps us encourage patients to switch them to insulin if required, and this will give them a more elaborate way of understanding how their blood glucose fluctuates throughout the day. In type 1 diabetes patients, sometimes we see that there is a coexisting celiac disease, and lots of patients come with variable blood glucose, lots of fluctuations around their diet. And that CGM, that said, when we use CGMs, we can pick up the food items that they are not tolerating or that they're giving spikes. In type 2 diabetes, this can be used in terms that very diet resistant patients can use CGMs and actually look at how their meals affect their post meal glucose. And this actually motivates and encourages them to reduce refined carbs in their diet and avoid certain food groups that were actually the culprit of this deranged blood glucose. And this, what is the glycemic variability and how is it assessed using a CGM? So glycemic variability is basically an average of the difference between the highest and the lowest values, and it is assessed after a 15-day period of 15-day period of wearing a CGM, or if you are checking earlier, at least 10 days is required to give a glycemic variability. So glycemic variability, once we say we are looking at all the values from lowest to highest or highest to lowest with the average blood glucose in picture, coefficient of variation that appears on that AGP report. So this should be ideally less than 36%. And you once you wear the CGM, you can see that available on the AGP report. So we can also see based on the graphs that we saw how differently that is behaving, how many times the patient has a hypoglycemia versus a hyperglycemia in each and every day report, in the entire average report, and the front page AGP report. So it can be assessed quantitatively on the first page and qualitatively in overall reports. So, a 28-year-old woman with a 10-year history of type 1 diabetes presents for routine follow-up. She reports frequent episodes of dizziness, sweating, especially at night, but her self-monitoring of blood glucose records appear mostly within target range. She uses multiple daily injections. So, what are the therapeutic adjustments you would consider based on the CGM report? First and the foremost, please check the glucometer. Lots of times patients trust their glucometers blindly and they have never been calibrated, because most of the glucometers that come are factory calibrated. And having said that, there is no repeat calibration. So we just cannot rely on SMBG. And with the CGM reports, we can also look at where the hypos are going, why there are hypos, the insulin time injection and the meal time, where is the patient exactly injecting the insulin and where they are having those meals. So how can a CGM reduce the risk of hypoglycemia in this patient? So wearing a CGM gives us so much of information about the patient that the patient would never actively recall or actively come and report these things to us. You can also assess if there is any period of exercise that is going in the daily routine of the patient where he or she is ignoring a pre-exercise snack or something like that. So CGM actually gives us a lot of information about where exactly the hypo is happening, what is the meal time, and what is the injection time, or what is the dose of insulin that the patient is taking. So once the patient comes in with this data, we can use the CGM reports to extrapolate and then decide and discuss the plan with the patient. So thank you. It was a wonderful session, Clarinet and all the audience, and I hope I was able to put some light on the CGMs and their use in everyday practice.
Thank you, ma'am. Thank you so much for answering all the queries of our participating doctors. And I
Thank
would also like to thank all our participating doctors also. And I would like to request you all to follow us on our Facebook, Twitter, LinkedIn, and Instagram pages for more medical updates. Thank you, ma'am, once again for your valuable time and for being with us. So, with this, we are concluding the session over here. Thank you. Good night,
thank you.
ma'am.
Good day.